Hey, it's the Second Opinion podcast with Dr. Paul Kolodzik, where we talk about anything and everything medical, from a sore throat to the future of AI medicine. Dr. Paul is an ER doc and certified in addiction medicine and metabolic health, as well as a best-selling Amazon author. You can learn more about Dr. Paul at his website, drpaulkolodzik.com.
Hey, Dr. Paul, welcome back. It's been a while since we've been here.
Yeah, great to be here, Terry.
Well, you took a little vacation, and I took a little vacation, and then we came back right after the 4th of July, so today is like July 7th or something like that.
Yeah.
And you came out to see the drone show over the holiday weekend that I helped the city put on.
For our listeners, Terry, as a producer, is involved in some community activities here and was in charge of the Centerville, Ohio entertainment for their July 4th festival, which draws, 80,000 people or something?
It was a record number. It is the largest one-day festival in Ohio.
Wow. And the number was at 80?
It's over 80,000.
Yeah. Yeah.
And it's a large, but this year we put on a drone show as well as fireworks.
So Terry gave me a heads up on this, so I took my family to see it. We had a great time, and I told him, of course, it was the best drone show I've ever seen. Okay,
it's the first drone show he's ever seen.
But it was pretty neat, and the technology is neat. 200 drones, right? 200
drones. Now you got to remember, in China they do 2,000 drones.
I can't imagine it. Does that mean the Chinese are ahead of us?
They are in drones. Yes.
Yeah. So just very, very entertaining. All kinds of pro-USA symbolism and designs, coordinated by the drones. It was very amazing. And then that was, of course, followed by a magnificent fireworks show. And then you were responsible for how many bands over the weekend at different locations?
Then we had 6 different stages with a total of about 12 to 15 different acts going on different stages from certain times. So, and it was hot. Tell them how hot it was.
It was like 94, 96, right?
And I think I had heat stroke. By the way, what is heat stroke?
I think you were dehydrated. I don't think you had heat stroke.
What is the difference?
Well, dehydration mean that your total body fluid's down. Heat stroke is when there's a significant increase in body temperature.
Oh, okay. Yeah, I think you're right, because I was just really dizzy.
Yeah.
And I said, man, I don't know if I can walk back. So.
And it really it goes dehydration, heat exhaustion, and then heat stroke. Heat stroke can be very serious, but it's relatively rare. So it means there's a mental status change. It means people, literally lose consciousns with a heat stroke. So the vast majority of these instances occur in the category of dehydration and heat exhaustion.
Yeah, well, I was somewhere in that range. I don't know where on that spectrum I was, but I tell you, by the end of that day, it took me a day and a half to even get halfway normal again.
And you are on the spectrum.
I am definitely on the spectrum of some kind.
Yeah.
So we're going to spend a lot more time on this podcast dealing with things that you deal with on a regular basis in the ER, because you've got some fascinating stories. We've talked about this offline that people don't get to hear, but I said, why don't we start sharing some of these stories with the folks listening in with us about things that maybe they don't realize that happen in the ER, or some medical things that you've come across in your other practices as well.
Right.
So where'd you want to start this with?
Let me tell you, I'm going to tell people about the young lady we talked about the other day.
Yeah, that's a good story.
Okay, so that is not in the emergency medicine practice, but in my addiction medicine practice. People talk, Terry. I mean, I've talked to colleagues, and they say, I wouldn't want my kids, other doctors that are my age, I wouldn't want my kids to go into medicine. It's become so complicated and so profit driven and all that. And, I just disagree.
Really?
I just think it's still a great calling, from a professional standpoint. There are other ways to make more money, but you're always probably going to make a reasonable living being a physician. And I just think, I still look forward to going to work and interacting with patients and going home at the end of the day. Part of this is maybe that, my wife's an emergency physician and we get to share stories. But I still find it very, very satisfying.
Yeah, isn't that the key to life? As long as you come home, feel like you've done something better today to help somebody, that's kind of the key.
Yeah, and now that's always intertwining now as I get into my mid to upper 60s about, are you going to slow down doing this? And I just, that's going to, we should talk about that sometime, because I just, it's a good thing and a bad thing, but you got so much of your identity wrapped up in, your profession. I would just, at this point, find it hard to step away from it.
Well, as long as you're still healthy and can do it, why not keep going? As long as you love it.
Yeah. So, anyways, that brings up the case of this young lady I have had in my addiction medicine practice for 5 years. And Terry and I talked about this the other day. And the reason this came up is because she is now starting her first nursing job at one of the hospitals here in Dayton on a cardiac step-down unit.
Yeah.
But the backstory is that she originally came to us. She's now in her late 20s. And she originally came to us after getting hooked on pain pills that were prescribed to her. So she
had an accident or something?
Yeah. She had an accident, and I think there was, an emotional background there as well, because she was abused as a child, and then had an accident, had some back pain. And that was back in the day when doctors were just passing out, OxyContin and oxycodone right and left. And one of the theories behind that, I don't think we've talked about this, was the pharmaceutical companies. We have talked about Purdue Pharmaceuticals.
Oh, I've seen several movies about them. Yeah,
right. But they pushed this theory, which was not based in science at all. And the theory was that if you have real pain, then taking narcotics really just offsets that pain, and you aren't going to get addicted. So if your pain's real, you aren't going to get addicted. That was the line that was sold for 15 years.
So was that part of that happy face, sad face thing?
Yeah, absolutely. Yeah, the fifth vital sign. Yeah, but pain is the fifth vital sign, which is craziness, because I've had people in the emergency department playing Tetris on their phone, looking up at and telling me that their pain's a 12 out of 10. Yeah. So that was a big mistake. You got to take pain seriously, and you need to treat it appropriately. But that was just part of the mechanism of the opiate epidemic that we ended up, because we were told if there was a frowning face there, you have to treat that. And when I say we were told, I was saying medical leadership in facilities, in healthcare facilities, hospitals said, you got to take this seriously. You need to treat this pain. We can't be getting patient complaints because you didn't give them enough pain medicine.
That's wild.
Yeah.
And that ties back into that movie. That if you haven't seen that movie, watch the movie about, what was the name of the family?
Oh, man, you asked me too quick.
Yeah, they're the guys who pharmaceutical companies, pharma, where I can't remember.
Yeah, the name of the company is Purdue Pharmaceuticals.
Yeah. Okay. So go back about this.
So, anyways, so she came to us initially, and this was a very typical story where she got hooked on pills from the doctor. Then there was a crackdown by the state medical board saying, you guys, we're creating all this addiction problem. You guys can't do that anymore. So a lot of doctors just it's like 1 month you get your pills, the next month, nope, I can't do that anymore. And so people went out on the street searching for medicine. And of course there was a shortage of narcotics on the street, and a lot of people turned to fentanyl. Either pills or snorting fentanyl. Some people obviously did recreational IV fentanyl and heroin.
Holy cow.
Yeah, this young lady never did, but she couldn't be without medicine because she would go into withdrawal.
And now, can you, I think we talked about this in way long time, can you die from withdrawal from narcotics? You can't do that, but you can die from withdrawal from alcohol. Is that right?
Yeah. So the most dangerous withdrawals are alcohol and benzodiazepines, things like Valium, for example, or Ativan. Those are the two very dangerous ones. In opiates, people don't die from opiate withdrawal, but the phrase that's used is, you feel like you're dying.
So where did this girl get the money for this stuff?
She would beg, borrow, and steal. She was living at home. She would sell, family member stuff, just anything.
And what made her basically reach out and say, I need help?
Well, so she got to the point where she realized, quite honestly, a lot of this is just her own ethic and her own, moral approach to life, is that she said, I don't want to live my life this way for the rest of my life. So she reached out, and what is typical in this process is you transition people from opiates off the street to a medication called Suboxone, which is medication I've prescribed in my clinics for years.
Yep. We
try and keep the doses low. Some clinics keep doses high to keep the patients coming back, but we've been successful at keeping the doses low. And she stabilized herself. And in stabilizing herself, she got a job working 40 hours a week.
Well, let me ask you about how long did it take her to go from fentanyl using Suboxone?
Yeah, you can do that transition pretty quick. You can transition people within a couple weeks and stabilize them. Yeah. Now, you usually have to start on a higher dose of Suboxone depending upon the amount of fentanyl used.
Okay.
But then you can ratchet it down over a period of time.
And how does somebody know that that's working? How do you know that, this is working for her?
Because she's not in withdrawal anymore.
So withdrawal, what kind of symptoms would you see if you're in withdrawal?
So there is a scale that you can use. It's sweating, it's your hair standing up on the back of your neck and your arms, it's palpitations, your heart beating fast, it's nausea, diarrhea, headaches, sleeplessness. So it's basic cramping, body cramping.
And how long does withdrawal last? If you did this without medicine, how long would withdrawal last?
Yeah, generally, it gets worse depending upon how high the use is within a period of hours. It can, within 6 or 8 hours, you can begin withdrawal. Some people need to have medicine need a fix every 6 to 8 hours. But then the worst is generally over within 3 to 4 days. But relapse is common. Yeah.
Let's say they get through the 3 to 4 days. They think they're clean, and something pulls them back into the addiction. Okay.
Right. So we treated her with Suboxone, and we had done that for a number of years, titrating her dose down to just a smidgen of Suboxone.
So she was on it for several years?
Yes.
Okay. But she was acting, at that point in time, she was very normal?
Stable. So she went out, got a job in a nursing home as a nursing assistant, working the night shift, working 40 hours a week on the night shift, and then decided she liked medicine and decided to go to nursing school.
Wow.
And that started, that was like 3 years ago. And just so she continued to work 40 hours a week, night shift, and put herself through nursing school over the course of the last 3 years. And, I'm meeting with her every month, initially some in person, but a lot of telemedicine. She's going ahead and coming in for her drug screens, making sure she's staying on track.
Right.
We're titrating down her dose of Suboxone.
When does that ever end?
The answer is yes for some patients. Some patients, though, just want to be on a low dose long term because they're so fearful. You can see
I don't blame them.
You can see it in their eyes.
I don't blame them a bit.
They're so fearful of going back to the place that they were at one point.
Yeah.
That they just feel like they need that as an insurance, and it's other than maybe decreasing cravings a little bit and keeping them out of withdrawal, it's not an issue. For example, she went and passed her nursing boards, a month ago.
That's fantastic.
Got registered by the state nursing board.
Yeah.
And you can do that on low doses of Suboxone because it doesn't affect your performance in your work. And, last visit I had with her, she was just so proud that, she's going through orientation at the cardiac step-down unit at one of the big hospitals in Dayton. So just a true success story.
Well, what makes this even better for her, that if somehow she ends up dealing with patients with similar situations, how sympathetic she'll be.
Yeah.
Right?
Well, I think she'll understand a lot about patient care, having been a patient for a long period of time.
All right. Hey, well, that's a great story, and we're going to end this podcast right now. But I got to tell you, that's a great story.
Yeah, if you have somebody, if you know somebody that has been dependent, there is this controversy about Suboxone. I mean, the term that's thrown out there is, oh, you're just replacing one medicine for another or one dependency for another. I think it's a great medicine. I think it needs to be used prudently.
Yeah.
But I think if you know anybody that would benefit from that because they're still doing pills or fentanyl, I would advise them in that direction. And the other thing is, if you know somebody that is on a limited amount of Suboxone, don't view that as a negative or a disparaging thing.
I totally agree. Yeah.
So some people still think it's got a little a nuance to it that that person is a druggie or dependent, but there's a lot of people on low doses of this medicine that have done real well. On the flip side, if you know somebody and they're going to a clinic that is keeping them on high doses indefinitely just to have a patient indefinitely and they aren't titrating it down, that's a problem too. So really, I think, it's good to make a transition to the medicine, but then over a period of months to years, you got to go ahead and wean that dose down.
All right, so we're going to end this podcast. Just, again, your book is out there about CGMs and blood sugar. If somebody's
and
interested,
a lot of sales recently we saw, right?
Yeah, if we were just out there on the website, it is crazy. Yeah. How does somebody get a hold of this book or find out more about this book?
Yeah, again, it's the best-selling. We're switching gears here to another topic, but the best-selling book on Amazon for continuous glucose monitoring for non-diabetics. If you just go to Amazon, put my name in and book, you'll find it. So,
all right. Well, Dr. Paul, thanks again. We're going to be kind of making our little podcast a little bit more focused and shorter. So thanks for joining us, and we'll be back again with another podcast with a second opinion and Dr. Paul Kolodzik.
Thanks, Terry.